Morning, everyone. Welcome to today's clinical meeting. We have five presentations for today. We'll start with Dr. Krupa, and her presentation is titled Look for the Common.
Good morning, everyone. My presentation is titled Look for the Common. We have a 16-year-old gentleman, 11th standard student from Jamshedpur, who presented with chief complaints of fever for 2 weeks, loose stools for 2 weeks, and abdominal pain for 2 weeks. History of present illness: patient was apparently well 2 weeks ago when he developed low-grade fever with no chills and rigor, which subsequently progressed to high-grade fever. Abdominal pain, which was generalized, mild to moderate in intensity, occasionally localized to the right lower abdomen. Patient also complains of loose stools, 3 to 4 episodes per day, semi-solid, small volume, initially no blood or mucus or no tenesmus. Multiple hospitalizations were present in the last 2 weeks for the same complaints. Fever had initially subsided but now recurred, and loose stools are continuously persisting with 3 episodes per day. There is a history of outside food consumption. Patient had been on ND-dependent drainage for the above-mentioned complaints from an outside hospital and on continuous bladder drainage. His treatment history is he was treated with injection meropenem, linezolid, metronidazole, azithromycin, colistin. Calcium gluconate was given, tramadol, ulinistatin was given. Outside report shows a chest X-ray with bilateral pleural effusion, and CT abdomen done outside shows GB wall edema with enlarged liver. There is diffuse circumferential bowel thickening with multiple enlarged retroperitoneal nodes and multiple enlarged mesenteric nodes. His past history: there are no comorbidities, mixed diet, there are no addictions, there is no history of contact with TB, there is no family history of malignancies, no feature suggestive of an autoimmune involvement, no rash, there's no joint pain, no recurrent oral ulcers. On examination, pulse was at 132 per minute, which was regular, BP at 160, respiratory rate at 24 per minute, saturation at 95% on room air. GCS was 15/15 with a GRBS of 100. There was pallor, icterus, and sacral edema. Left cervical and bilateral inguinal nodes were palpable. There's no clubbing, no peripheral signs of infective endocarditis. CVS, patient was tachycardic with normal S1, S2. There are no murmurs. Respiratory system, they were minimally reduced, bilaterally basal breath sounds were reduced. Otherwise, there was vesicular breath sounds bilaterally. Per abdomen was soft and non-tender, but it was distended with shifting dullness positive. Liver was just palpable. Top space was resonant. CNS did not show any focal deficit. The clinical syndrome that we have is fever with loose stools and abdominal pain post 2 weeks of illness with pallor, icterus, and subcentrimetric nodes, ascites and pleural effusion clinically. So what are the differentials that we can think of? Any differentials that we can think of? Okay, so these were our considerations also when we saw this patient. So the differentials we considered were infective enteric with a fulminant course, disseminated tuberculosis, autoimmune SLE with serositis and overlap, inflammatory bowel disease, vasculitis with flare, malignancies like lymphomas and leukemias. These were the baseline investigations that we had. HB at 8 gram initially, total counts at 3,500, neutrophils of 45, lymphocytes of 45 and 43, lymphocytes of 45 and monocytes at 12, platelets at 1,95,000, urea at 61, creat at 0.7, total bilirubin at 2.6 and direct bilirubin at 2.14 with a total protein of 6.3, albumin of 3.5. SGOT-PT was elevated, SGOT at 265 and SGPT at 74. Alkaline phosphatase was also grossly elevated at 831. GGT showed 596. Ascitic fluid analysis was done, which showed a high SAG, high protein ascites with WBC count of 300 and RBCs of 2,200. There were reactive lymphocytes that were present. Pleural fluid also showed WBCs of around 400, RBCs of 10,000. Reactive mesothelial cells were present. Malarial parasite was negative. Because the patient came in third week of illness, a Vidal was done, which showed O antigen at 640 initially. Serial Vidal showed O antigen persisting at 640, then the third one was negative. H antigen with high titers of 2,560 persisting for the next sample, and again it reduced subsequently. Vasculitis workup was negative. Blood culture showed no growth. Bone marrow had trilineage hypoplasia, rest normal. The course of the patient. Patient developed hematochezia with Vidal positive. We thought the diagnosis that we thought of was enteric fever. Patient developed hematochezia with rapid drop in HB during the course of admission, requiring transfusion of 3 PRBCs. Pleural effusion was an exudative pattern. Imaging ruled out a hepatic vein obstruction. Multiple cultures were sent, blood cultures, ascitic fluid, pleural fluid, bone marrow, all of them were negative. TB was ruled out because bone marrow and expert MJet, everything was negative. Empirically, patient was started initially at admission on meropenem and azithro 1 gram OD because we were considering salmonella as a differential. Vidal, which was sent initially, came back positive, so meropenem was stopped and azithromycin was continued at enteric dose. Gastro opinion was taken in view of the persistent hematochezia that the patient had. Gastroscopy showed an erythematous mucosa with chronic gastritis. Colonoscopy showed erosions and bulky mucosa of the terminal ileum, and probably that was the cause of the hematochezia that the patient was presenting with. CT abdomen suggested inflammatory bowel disease. We continued the patient on injection azithro 1 gram. Subsequently, fever subsided. GI bleed also resolved. Serial Vidal titers were confirmative of enteric fever. So this is a classical third week severe disease that we see with hemorrhagic enterocolitis, high Vidal titers, and just giving the patient azithromycin at enteric dose alone was sufficient for the patient. Subsequently, ascites in the pleural effusion and the LFTs also improved. Just a small article on complications and mortality of typhoid fever. It's a systematic review and a meta-analysis. So just want to highlight the fact that gastro among Asians, not just Asians in general, the abdominal complications of hepatitis is the highest, followed by gastrointestinal hemorrhage, which was actually seen in our patient. Among cardiovascular complications, patients generally present with shock, myocarditis. Neuropsychiatric, they can present with features of delirium, meningitis, and encephalopathy. And respiratory system can present with pneumonia. Hematologically, they can present with anemia, which is very common, along with DIC. Other complications that we can think of is on focal abscess, pharyngitis. In pregnancy, it can cause miscarriages, relapse, and chronic carriers. So the learning point is typhoid is a very common disease. We cannot miss out a severe disease like that, especially patients presenting with hemorrhagic enterocolitis. Those need to be picked up. And the treatment is to persistently give that azithro 1 gram OD, treat the disease rather than adding a lot of which the patient was on when he had come actually, multiple different drugs. So typhoid needs to be picked up even when it presents with a lot of complication, and that can be misleading. Thank you.
Thank you, Dr. Krupa. Any comments, questions?
The presentation was way more exposed. He did not present to us just with loose stools. He actually presented with melena and hematochezia, where multiple transfusions did not bring his hemoglobin in one day. So we were actually thinking fulminant ulcerative colitis, necrotizing enterocolitis, more serious diseases. The presentation was way more explosive than what was discussed. But yes, he came in that classical third week, and he had some thickening on the imaging we did on day one in ileocecal region, which is only seen in TB or enteric. So which is why we covered it.
He had any blood cultures from outside, Krupa?
Blood cultures from outside also did not grow. Any of them, they've not shown salmonella.
He was treated with azithromycin at enteric dose
With
outside.
the enteric dose.
Not at enteric dose outside.
Not over
He's
here.
got normal dose, but he's got a multitude of antibiotics, no cultures positive. What is your understanding of wide eye? Because the whole diagnosis here is based on wide eye. What is your understanding of wide eye?
It's a serological test. Generally, it looks for the H and O antigens that are there. Generally, the concept is O antigen generally rises early on in the disease and then falls. H antigen generally takes time to rise and it's more
What is this O and H? And are we checking typhi or paratyphi?
We're checking both. O and H is for typhi, and there are paratyphi A and B that we also test.
Should we cover wide eye?
Thank you.